With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. Do your patients know what presbyopia is?
There are people who are afraid of the press.
Have you talked to your patients about multifocal contact lenses?
I've heard the bifocal, but not multifocal.
Exactly, not multifocal.
Do you need help with your multifocal strategy? Learn more at the conclusion of this episode.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with MicroMicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and MicroMicelle technology.
Good morning, I'm Dr. Kerry Gelb, and welcome to Open Your Eyes Radio. Please listen as I discuss the newest information in the world of health, nutrition, and sports every Saturday morning, 9 a.m. Central Time on AM 1280 The Patriot. And also, please share your thoughts by emailing me at drkerrygelb@gmail.com. That's drkerrygelb@gmail.com. We're back with our special guest, optometric physician, Dr. Steve Rosinski. He's a contact lens expert. He works with CooperVision. CooperVision is a global leader in contact lenses. In 2019, he became a senior manager of professional and academic affairs. He teaches physicians. He consults on newest contact lens designs. He's an avid athlete. He's earned his USA Triathlon Elite Pro license in 2011, where he's been racing pro for the last 12 years. He's a good friend and a really nice guy, and he's here to share insight on contact lenses, to get inside the industry a little bit, to get deep into the industry, because as we talked about last week, in my opinion, and I think opinion of people who wear contact lenses is really an unsung hero, a miracle of medicine, something that is really taken for granted, that you could take this little piece, this little clear plastic disc made up of partly of water and see amazing, be comfortable. Most of the day in the old days, contact lenses would get dry and you wouldn't be able to see out of it. I remember older patients would come to me, and before there were soft contacts, they used to have to wear hard contact lenses, and they would tough it out because they didn't want to wear glasses, because back then there weren't fashionable frames. They just had that black frame, and they hated the way it looked. But now contact lenses have come a long way, and we have single-use contact lenses, which I feel are the best contact lenses and the safest contact lenses and the best way to wear contact lenses. But they are a little bit more expensive, and not everybody could wear, because of course, single-use contact lens. But if it's something that you can afford, it's much safer than a 2-week or 1-month contact lenses. And there was a study done, it was actually funded by CooperVision, that proved that. And it was probably 5 times safer than soft contact lens. But, some people still have to wear 2-week or monthly contact lenses, but all the major manufacturers make daily contact lenses. Steve, a comment about single use or daily contact lenses.
Yeah, no, absolutely. When we look at the opportunity for your overall best contact lens wearing experience, that is going to be a daily disposable contact lens. In this day and age, when convenience is king, I do know that one of the biggest reasons that patients are transitioning, not only from a health perspective, a comfort perspective, but a convenience perspective, with transitioning over to a contact lens, that you put a fresh lens in each and every single day. And I'll tell you, every single time that I've introduced a daily disposable contact lens to a patient, they are intrigued. They might not have heard about it, but they are definitely intrigued, because they all know how good it feels from a comfort perspective to put that fresh lens in when they are maybe a monthly wear at the end of that month, or a 2-week wear at the end of those 2 weeks. So having that fresh lens feel each and every single day, that is definitely something that patients are excited about. And I tell you, my first pair of daily disposable contact lenses came when I was in optometry school, and I couldn't believe it. It was life-changing. And so for me, as an optometrist, I always like to really be able to showcase the newest technologies and really be able to highlight the benefits of wearing a daily disposable.
You know, in this segment, we're going to talk about myopia, which is nearsightedness. You can see near, but you can't see far. And nearsightedness has exploded. In 1900, there was about 3% of the U.S. population was nearsighted. Now it's about 45%. And by 2050, it could be as high as 60%. Soon, about half the population could be nearsighted. And we could treat nearsightedness or myopia. First, before we get into the treatment of nearsighted, because we're going to talk a lot about that, because a lot of people listening to this have children or grandchildren, and they want to know how they could prevent their kids from wearing glasses or needing very, very strong glasses and prevent their prescription from getting worse. First, Steve, what is myopia or nearsightedness?
Yes. So, you know, Carrie, this personally hits home, right? I am a -9 myope, which means I'm considered the high category of high myopia. And, you know, also I have 3 little kids, right? I have a 6-year-old, a 4-year-old, and a 2-year-old. And so when I look at hopefully having my children have better eyes, we always want what's better for our children, right? I want to have better vision, better health outcomes, better success than that I have as a parent. And when I look at myopia, it really hits home because myopia in itself is where the eye is growing longer than it should be, especially when we look at kids developing myopia. A lot of times as they are growing, the eye is becoming longer, it is becoming weaker, and it's growing faster than it should. Prior to my, becoming an optometrist, realistically, I just knew as I continued to grow that my vision for myself continued to get worse. And I became best friends with my optometrist because I was having to go back maybe on a 3 or 6 month interval, but we really couldn't do anything about it at that point. It was just getting a stronger glasses prescription, a stronger contact lens prescription, and hoping it didn't change too much in the subsequent months. But ultimately, though, it is so nice knowing that, as a parent, and I imagine that there are many individuals out there that believe the same thing, that they went through the same steps that I did. Was, we just got stronger glasses. Well, when it comes with stronger glasses, that's actually not a good thing. Higher myopia isn't a good thing. We talk about being stronger as athletes. Well, we don't want stronger prescriptions. We want to minimize that prescription. We want to try to do everything we can to prevent that eye from getting longer than it should be. But in simple terms, myopia is an eye that's longer than it should be. And when we have a growing epidemic, I would like to say, of patients that are becoming more myopic more quickly. And, Carrie, I'd like to point out that you said, that stat of over 50% of individuals throughout the world will be myopic by 2050. What's even crazier is the number of individuals that are going to be considered highly myopic. That's considered, like, the technical definition is -6 or higher. But that number of individuals could be upwards of 1 billion by 2050.
And as eye doctors for many years, there was nearsighted, there was farsighted, there's astigmatism, there's presbyopia, not be able to see up close. And we never really thought much about myopia. You're nearsighted, you come back the next year, you're more nearsighted, you come back the next year, you're more nearsighted. But now there's something that we could do about it. Now, would you consider myopia? Brian Holden said it's a public health issue, but would you consider myopia now a disease?
Well, when we look at myopia in general, diseases can, when we really think about it, it could be something that causes something to get worse, right? And, when I look at myopia across the board, I'm seeing that individuals' eyes are getting longer. Their tissue of their eye is actually getting weaker as well. So it depends on who you look at. Some would say it's disease, some wouldn't. But I think in more optometrists' mind and more eye care physicians' mind now than ever before. They're looking at it as more of a disease than not, especially as we continue to see the prevalence continue to increase.
And now that we could do something about it. So, I mean, why do you think back in 1900, 3% of the population was myopic, and now over 40% is myopic?
Well, I think it's a combination of factors. I look at genetics as well. If an individual is myopic and they have a child with another individual that's myopic, the risk of that child that they have increases that likelihood of that child being myopic. That's one. Two, I think about how we are spending less time outdoors. Outdoor time really does matter when it comes with helping prevent myopia from getting worse. And we also look at a lot at up close objects, at digital devices as well. So when we look across the board of the overall environment, so there's the genetics, but then there's also our lifestyles and our environment are different than they were a number of years ago. And that really is helping really speed up the rate at which individuals are becoming myopic.
If you could continue on that and maybe repeat a little bit for the people who have just joined us, this is so important. Why are we becoming nearsighted? Where back in 1900, only 3% were nearsighted. Now over 40% are nearsighted. Why is that happening?
No, this is a really important topic to myself, as well as I imagine a number of individuals, either listening to this call because they as well experience myopia, or maybe they have children that have myopia as well. But ultimately, we look at it from a combination of factors of our genetics, but also our environment and our lifestyles that we live in. When we really look at screen time, probably one of the biggest questions I get asked when talking with parents of children that are in my chair is looking at it from a standpoint of, how often should my children, how long can they really be looking at devices online or devices, iPads, cell phones, watching TV, and all of that lifestyle, all of the staying indoors, staring at digital devices more at a closer distance, that all adds up to increased risks of patients developing myopia. When we look at it for screen time, what we are figuring out is that there are certain growth signals in the eye that can promote myopia and nearsightedness progression. We know that that when it comes with education, individuals are on tablets and computers, and we are using them more than ever before. But we recommend that we actually not hold screens as too close, back a little bit, and as well as taking breaks. I think that's very important, the aspects of taking breaks, to really be able to give your eyes the ability to relax. And, so for every hour of near work, taking a 5-10 minute break really is really beneficial for that child. And honestly, for us as well, I would say, Carrie, and it's getting outdoors, spending time outdoors has been shown to be really beneficial as well. So, trying not to hold things as close, not staring at a device for long periods of time without taking breaks, and then getting outside is going to be of benefit.
When I was a kid, my mother used to yell at us to come inside from playing outside. Now the parents are yelling at the kids to go outside and play, because the studies are clear. If you're not outside, you have a much greater risk of getting nearsighted.
Yeah, and when we look at that, it's really the goal would be 2 hours a day of outdoor time, Carrie. I know it's harder in certain areas of the world, in certain areas of the United States than others. But the goal would be 2 hours a day if you can get your kids outside. I know personally, I like to get my kids outside, at all hours of the day, but just to really be able to let them burn off some steam, not only for the lowering risk of hopefully myopia as well.
Myopia comes with side effects, high myopia. If you could address some of those side effects.
Yeah, so when we really look at myopia, not only is it a visual issue, that the individual that has myopia isn't able to see as clearly off in the distance, but it also increases risk of certain ocular conditions, especially as we continue to get older. As someone who has myopia, their eye is getting longer than it should be. It's getting thinner than it should be, or weaker than it should be. That puts us at risk for certain disorders. I'm sure many of you have heard of cataracts before. Well, there's an increased risk of cataracts the more myopic someone is. Many of you have probably heard of glaucoma before. Glaucoma in itself is a disease that has a higher risk of developing when someone is myopic. And macular maculopathy, or essentially an issue with a disease associated with the retina, or like your central vision, that allows you to see as clearly as possible. So it's not just a visual issue. We like to think about it as if we can try to make sure that eye isn't continuing to grow longer, continuing to grow weaker, that we can also help later on down the line with someone who hopefully we can prevent them, or not prevent, but slow down their risks and decrease the risk of developing glaucoma, macular degeneration, cataracts as well.
So just to give the viewer a little bit of a perspective, retinal detachment, the greater the longer the eyeball, the greater the risk of retinal detachment. We want to try to prevent that. If you could tell us what a retinal detachment is and what kind of tests a doctor needs to do to see if somebody's at risk for a retinal tear or a retinal detachment. And unfortunately, that has to be an in-office test. That's not something that can be done by telemedicine.
So essentially, the back portion of your eye has a layer called the retina. Without the retina, we wouldn't be able to see. And that retina, in individuals that are highly myopic, they are at more risk for this retina to actually detach from the rest of the portion of the eye. And what we see with that, though, are when we look at the different risk factors and what we are looking for as doctors, individuals that have those thinner areas of the eye due to myopia, they actually are at higher risk for this retinal detachment. And when we are looking at the eye in an exam, many times individuals get dilated. So we are dilating your eyes to be able to view into your eye, into your pupil, or essentially the black portion of your eye, able to get a better view of the whole entire eye. So that we can assess to make sure there aren't any thin spots in your retina. If we see thin spots, that individual is more at risk for retinal detachment than those that don't. Doesn't mean they're not going to have a retinal detachment. They're just at a lower risk if we don't have those thin spots. But we are looking to assess to making sure that those individuals don't have those thin spots. Carrie, even I remember a few years back, I had a patient that was a young female. She had no symptoms of anything. And I just did my yearly annual dilated exam on her. And I noted that she actually had the early stages of a retinal break, or a retinal thinning spot. And we were fortunate enough to catch it early enough that it actually didn't lead into a retinal detachment. And I'm sure you've seen that in your career as well. But for your patients as symptoms, what are you looking for? I would highly encourage you, if you're all of a sudden see a sudden onset of a lot of what are called floaters, or little black spots in your eyes that really aren't gnats off on the side, but essentially in your eye, you're noticing these floaters that are sudden onset. That's one definitely big symptom that you want to go and talk to your eye care physician. Also, flashes of light. If you have flashes of light off to the side, that is another symptom of a retinal detachment. And then also, if you feel like you're losing some of your vision, some of your peripheral vision, then that is definitely another symptom that is of a retinal detachment. And as eye care providers, yes, we are assessing your visual, your visual system, but we're also assessing, making sure that the health, it's not just all about the glasses, all about the contact lenses, but we are looking to make sure that you don't have any of these signs that we are seeing that could lead to this retinal detachment. And retinal detachments, when I think about it as an eye care provider, they can be complex. Many times patients can have permanent vision loss. Fortunately, if caught in the earlier stages, we can have better outcomes. But the goal is to not have that retinal tear, retinal detachment in the first place. And if we can try to decrease those risks, like with slowing down myopia progression, then that would only benefit from overall public health. Hopefully not as many individuals will have retinal tears, retinal detachments later on in life as well.
Yeah, and we mentioned cataracts and glaucoma, and many patients mix those two up. With cataracts, I did a great podcast with Dr. Jeff Levinson. Go look at that past podcast, that past show. And for glaucoma, I did a show with Jeffrey Goldberg out of Stanford, and that's on the podcast so that you could find that on YouTube or any of the podcast channels. So just briefly, if you could tell us about what a cataract is and what glaucoma is and what's the difference?
Yeah, so quickly is the cataract is actually has to deal with the lens more like towards the front portion of the eye. We all have a lens that allows us our eyes to focus up close when we're younger, also allows you to focus light so that we can hopefully help see clearly in the back of our eyes. As we get older with various factors, maybe excess UV, being out in the sun for a while, certain medications can increase your risk of cataracts. And when we look at it as well as there are certain lifestyle habits such as smoking increase risk of cataracts. Cataracts essentially is a cloudiness of that lens. Essentially, you're looking through a cloudy window. It's not as clear anymore as it was when you were younger. So essentially, a cataract is a cloudiness of that lens. And patients have cataract surgery when we actually take out that cloudy window and we're able to put a nice clear lens back in. And that's traditionally part of cataract surgery. When we look at glaucoma is actually a disease of the optic nerve head. The optic nerve head actually attaches the eye to the brain, essentially in our bodies, and that tissue dying off of that optic nerve head is essentially glaucoma. Sometimes patients correlate having higher pressure inside the eye with glaucoma, but that is actually just one item that we look at as optometrists of looking at pressure as one indicator of glaucoma. Some individuals that I have high pressure and don't have glaucoma, and some individuals have low pressure and don't have glaucoma. But a glaucoma affects essentially the tissue surrounding your optic nerve head.
We're talking with Dr. Steve Rosinski, optometric physician. He's our guest, and after the break, we're going to talk about what you could do to prevent myopia from getting worse.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
We're back with Dr. Steve Rosinski, optometrist from Northern Virginia, Leesburg, Virginia. And he's an optometrist. He's an optometric physician. We're talking about eyes. We're talking about contact lenses. And we're talking about myopia, the epidemic of myopia. Myopia was 3% of the population in 1900. Now it's 42%, soon to be 50%, soon to be 50% of the world. What are we doing with all these digital devices and not going outside and becoming more nearsighted? But there are things that we could do as doctors and as patients to lower our risk of becoming myopic. And that's what we're going to talk about in the rest of the show here. So Dr. Rosinski, first off, who's at risk for getting myopia?
When we look at development of myopia, I would say looking at our children, right? Our children are the future, are our future, and we have set them up as hopefully as parents to have the most successful lives possible. We always want better for our children. But when we look at the children of today, they are more at risk for myopia than ever before. And when we look at the importance of trying to assess if a child has myopia, it's the importance of really being able to have that child have an annual eye exam. When I was in really diving into the pediatric space, we really even assess children as young as 6 months old as a part of infancy exams. So I know there are certain state regulations that have where a child has to have an eye exam before entering kindergarten. But it's essentially, looking at that child and really being able to, with care, being able to see what risk factors do these children have, and can we catch any signs or symptoms of any diseases such as myopia early on. And so I think that's really where the key is here, is Carrie, is having our listeners here, if they have a child, if they have grandchildren, the importance of going to see an optometric physician, going to see an eye care provider for an annual eye exam to assess that health of that individual, assess the refractive error of that individual. Because when we really look at learning, there are a number of difficulties that children have due to vision. And when we look at that, whether it is a vergence issue or like a muscle imbalance issue, whether it's a focusing issue, or whether it is a refractive error, there are many issues that can arise due to myopia as well. And that's really where it's important for us to intervene as eye care providers on the earlier stages, or maybe even what's called pre-myopia, where someone has a prescription that's going to possibly lead to a higher risk factor of myopia later on as well. So I always like to say, to intervene as early as possible. And in order to do that is to really be able to give an eye exam to that child starting at a really young age.
And before we talked about screen time, and the American Academy of Pediatrics, less than 18 months recommends no screen time. From 18 months to 2 years, maybe limited, very limited use, 2 to 5, 1 hour maximum, but you got to get outside. And over 6 years old, they recommend that you really need to place limits, because this has been linked with myopia. So what are the traditional ways that we treated myopia? How did we do that?
Yeah, so essentially it was giving a pair of glasses, single vision glasses, giving single vision contact lenses, and it really wasn't doing much except helping the child at that current stage. It wasn't doing anything to prevent that individual's prescription from getting worse or their eyeball from getting longer, because as we've mentioned before, myopia is where someone has a longer eye, and we don't want that to happen. However, single vision glasses, single vision contact lenses have been shown that really doesn't do anything except help that individual see. It has no treatment effect to slow down that rate of progression.
So what can we do now to slow down the rate of progression? What are the different categories of things that can be done?
Yeah, so I like to break it down into a few different aspects. So we look at it from behavioral changes that we can do. Behavioral, to try to decrease that risk of progression, is getting outside, as I had mentioned and previously, is getting outside for 2 hours or more if you're able to. The research really strongly points to children getting outside is going to really help in decreasing that risk of progression. Also, trying to take breaks from a behavioral standpoint, taking breaks and not staring so closely at up close devices, being able to push back the near point and be able to maybe not look at that digital device or reading material as closely as possible, and taking breaks, every hour, taking a 5 to 10 minute break. When we look at outside of behavioral changes, so getting outside and changing like the working distance, we're looking at different aspects, whether it be contact lenses, different medications that have been shown to be of benefit in helping decrease that risk of progression. When we look at contact lenses across the board, there are 2 categories of contact lenses. There are soft contact lenses, and then there are also what are called orthokeratology contact lenses. These orthokeratology contact lenses are actually GP contact lenses that are shaped differently, that actually you actually sleep in at night with, which is a little different than most people think about. But I know, Dr. Gelb, that you've been a proponent of orthokeratology for years, ever since they became FDA approved back in 2002. But essentially, this is one avenue of the contact lens realm, in that the cornea, or the front surface of the eye, is reshaped at night, not only helping the individual see, but also helping with decrease the risk of progression of that child while wearing the contact lenses at night, and then they can see clearly throughout the day. So it's having both that treatment effect and also being able to help that child see. When we look at it from, and we can dive more into that ortho case space if you like here, Dr. Gell, but also think about.
Let me just interrupt. I'm sorry, real quick. You said GP contact lens. I don't think the audience knows what GP means.
Yeah, no, great. I'm glad you mentioned that. So gas permeable is essentially, when we can break that down, there are hard contact lenses and there are soft contact lenses. And essentially GP is going to be your hard type of contact lenses. Doesn't mean they're hard and they're going to hurt your eyes by any means, but it is just a different material of contact lenses that we use. And traditionally, it's a GP material that is being leveraged within orthokeratology, essentially leveraging this contact lens to fit on your eye and reshape the front surface of the eye while the individual is sleeping to have the desired outcomes that we had just talked about.
You know, when we look at Lasic versus Ortho K, Lasic, we're removing tissue. With Ortho K, with the gas permeable contact lenses, we're moving tissue off to the side. It's like a mold. The front of the eye is like silly putty. And we're instead of removing the tissue, we're pushing the tissue off to the side in this like groove. And the tissue goes into the groove. And by doing that, it makes the front of the eye thinner, and it changes how the eye is able to refract the light. And it's able to, depending on how much tissue you move or how much tissue you remove, you're able to put the light back on the eye so somebody could see. If you could explain that a little bit more.
Yes, essentially, when we really look at that front surface of the eye, we're talking super thin tissue here. We're talking about 70 microns of tissue that we are really adjusting here. And by having that orthokeratology lens go on top of that cornea, just like Dr. Gelb says, it's essentially shifting the tissue and allowing the lens to alter the shape. And what's unique about this is that essentially, if a child wears a contact lens overnight, depending on the prescription, because orthokeratology only does work for certain prescriptions. It's FDA approved for a certain amount of myopia, up to a -6, and then also a certain amount of astigmatism. If we're going to put a number on that as well, it's up to -1.75 diopters. But essentially, it's been shown through FDA approval, which I think is critical. Is FDA approved since 2002 that this is a safe to wear overnight, and essentially by having this contact lens on the eye, it reshapes the front surface of that cornea, that 70 micron tissue of epithelium, to really be able to allow the individual to see clearly, but also it has been shown to have a mechanism of actually slowing down the axial length or the length of the eye itself.
You know, I'm hoping that someday you're going to be able to put this gas permeable contact lens on the eye. You're going to set the prescription basically back to 0, and there'll be a drop, almost like a glue that you'll put in the eye, but not glue, of course. You don't want to put glue in your eye, but a drop that will be able to hold it, so you won't have to wear the contact lens every day, but maybe once a week to reset it. Has anyone ever talked about something like that, or am I in dreamland?
Well, to tell more of your listeners, essentially, this lens has to traditionally, this orthokeratology lens has to be either worn nightly or in some prescriptions every other night. And essentially, there can be the technology wears off towards the end of the day at times. And depending on prescriptions, you have, like I said, wear it at night or wear it every other night. So not that I've heard, Dr. Gelb, of this technology. I can see how from a compliance standpoint, that would be amazing to not have to worry about wearing a contact lens as much. But I can say that there are a number of individuals here in the United States and worldwide that have had such success leveraging this, especially not only to help see clearly, but also to help prevent their eyes from getting longer.
You know, I brought that up to one of the cross-linking people, and of course, cross-linking deals with the stroma, not the epithelium, which is a different part of the eye, but maybe someday. You know, we're talking about the different treatments. We were talking about using a gas permeable lens, which is a harder type lens that the kids sleep in to prevent them from getting nearsighted. You know, studies show up to around 60, 70% you could lower the risk. I've been doing this in my office for many, many years, and I could say that it's very good. It works very good. It decreases the progression at least by 70%, at least in my hands. I've had very good luck with orthokeratology. CRT is one of the brands that I use and have very good luck. And Dr. Steve, I really appreciate you sharing that. And it's about moving the tissue rather than taking away the tissue, because the front of the eye has 70 microns. It's called the epithelium of the cornea. The cornea, basically, for years we said had 5 layers. Now they may be discovered a 6th layer, but for all intents and purposes, say 5 layers, and that front layer is 70 microns. So for every 10 microns or 13 microns we move, we change the eye about a unit, or we call diopters. But let's move on to the next thing. Now there are approved soft contact lens, something called MySight, and your company that you work for, CooperVision, did the technology, they did the research. You know, not that it's a conflict of interest, everybody knows about MySight, but you know, in my hands, it decreases, and the studies show about 60% decreasing the risk of progression. But tell us about this special soft contact lens, how it works and why it works, and does it, and it's really something that now in 2000, in the year where we are, 2023, that we have this type of technology that could help these kids and lower the risk of getting nearsighted.
Yeah, no, it's truly remarkable, Carrie, of the options as optometrists and eye care physicians that we have to really make a difference in the lives of so many children out there. When we look at the various, aspects of myopia control, really looking at MySight truly is, it's an easy to fit single-use contact lens. And it is the first and only soft contact lens designed for myopia control, and it's FDA approved to slow the progression of myopia in age-appropriate children. I remember back in 2019, fall 2019, when we got FDA approval, how monumental of a day it was to have FDA approval of this product, because we know what that seal of approval really means for patients, for parents, and its importance as well. I was actually out on a bike ride, knowing who I am, Carrie, you'll appreciate this. I was out on a bike ride along the Pacific Coast Highway, and my back of my pocket, my phone was blowing up, and I'm like, what is going on? I kept getting text messages, phone calls. So I finally pulled over, oceans to my right, and I look at all my messages, and it says, congratulations, way to go. This is amazing. And this is my optometry colleagues so excited that MySight one day was able to have FDA approval on that November day in 2019. And it really is really helps from the momentum of really helping make myopia control, myopia management the standard of care for our pediatric children. I mean, for our pediatric population, for our children. And when we look at MySight, the unique thing about it is it fits just like any traditional soft contact lens, but it's dual purpose. It helps correct the refractive error that child has. If little Johnny is 20/60 or can't see very well and requires a -2 contact lens, well, then they're going to be able to help see clearly. But they're also going to have the opportunity from a treatment effect to help slow the progression of myopia in these age-appropriate children. It's unique in that it's doing that dual purpose, that dual opportunity to help correct vision, but also slow down the rate of elongation or progression. And it has really opened up an avenue for so many patients and so many prescribers. As us as eye care physicians, we look at obstacles, and we want to make sure that we make it as easy as possible for patients to really benefit from the latest innovation, latest technology. And with our MySight one-day contact lens, with being able to have that high efficacy of slowing down the rate of progression, but also helping individuals see clearly that would still need some sort of glasses or contact lens prescription in order to see clearly. We have this dual purpose effect. And, with talking with my colleagues over these last few years, I know yourself included, it really has opened up a whole new avenue of options to really hopefully help slow down that rate of progression and really affect thousands, millions of children that are in the world.
Everybody's sitting at home and they want to know, how does it work?
Yeah, no, great question. So a child doesn't have to do anything differently. As a parent, you don't have to do anything differently either. By placing the contact lens on the eye, the child doesn't have to look out of it differently. All they have to do is honestly is wear it. When we look at the studies that showcase the efficacy of the lens itself, if those children in the study that showcase this 59% efficacy in axial length, in refractive error, what we found is that these children wore the lens on average 10 hours a day, 6 days a week. And so for them, by wearing it, and the unique technology of it is it's a dual focus lens. So what I mean by that is one aspect of the lens allows the individual to see clearly off in the distance, and the other aspect of the lens allows the image or the light rays to actually land a little bit in front of the retina or the back of the eye, helping to slow down that elongation of the eye or the lengthening of that eye. So that dual purpose, being able to see clearly, but also have that treatment effect. And it's simple, it's easy, because all they have to do is wear it, and that child is benefiting from my sight.
And in the periphery, where does the rays land? Does it land on the retina? Does it land behind the retina in the peripheral part of the lens?
That is actually landing in front of the retina, Yeah, so it's nice and clear. So the center treatment zone allows you for the rays to land right at the macula so that child sees clearly. But the peripheral rays with the unique design allows for the rays to land actually in front of the retina. And that actually kind of pulls the retina essentially towards the light rays to focus and hopefully help prevent that child from their eyes from growing longer.
And this is a daily disposable, right? Isn't that amazing?
Exactly. So not only is it simple just to wear, but it's simple from a modality standpoint as well. These children put the contact lens in the morning, and then they take it out and they throw it away when they're done. And you might be asking, all right, should children be wearing contact lenses? And Carrie, I'm a big advocate of getting children in contact lenses, and it's actually been shown that not only can they actually learn how to take a contact lens in and out very readily, they are compliant. They actually replace their contact lenses each and every single day. They don't sleep in their contact lenses. And it's been shown to be very safe as well for children to wear these MiSight one-day contact lenses as well. Very safe and effective.
In my experience, children are able to take contact lenses in and out much better than adults.
I've seen that as well in certain times, absolutely, especially ones that are motivated.
So as we're finishing up, we talked about Ortho K, which were the gas permeable. We just talked about soft contact lenses to decrease nearsightedness. Let's talk about the pharmaceutical management. If you could speak to that.
Yeah, absolutely. So when we look at, there's a pharmaceutical mechanism leveraging what's called atropine. Atropine's efficacy in slowing eye growth really is unclear, like the mechanism of action for it. But what we do know is that it definitely has, in a number of studies and in certain concentrations, shown to decrease elongation, decrease progression, relatively effectively as well. So as we look at this as an option, maybe individuals aren't good candidates for MiSight, which is the only FDA approved for myopia control. Just like orthokeratology, which is not FDA approved for myopia control, that is also leverage what's considered off-label. But leveraging atropine is also considered off-label, but a number of studies have showcased its efficacy in helping prevent axial length elongation or myopia progression from getting worse, but also a safety profile. And essentially, atropine in itself is a medication that actually, with what you would see from if an individual took it, it would actually allow the eyes muscles, the accommodative muscles, to relax a little bit, and it would also allow the pupil to get a little larger. Although we don't know the exact mechanism of action, like I had mentioned previously, it can be a great option for many individuals that can't wear contact lenses as an option, or for maybe possibly leveraging, in your case, Dr. Gelb, I'm sure you've used it on additional populations as well.
I want to thank Dr. Steve Rosinski for joining me today. If people want to find out more about you or what's new at CooperVision, give us something new, what you're doing with sustainability, which is really cool, in 20 seconds before we wrap up.
Yeah, no, so we love the opportunity to really be able to not only make a difference and help improve the way people see each day with our products, with our technologies, but also we want to do what's right for the environment. And so we've partnered with Plastic Bank, and they are a global partner that helps with the collection of ocean-bound plastic. As a contact lens manufacturer, we produce a lot of plastic, and that plastic then can go out into the environment. Well, what we want to do is not only do we want to help manufacture contact lenses in an environmentally friendly manner, we fortunately have LEED certification sites that are throughout our global manufacturing facilities, but we also have a net plastic neutral campaign. So essentially, what is that? We have the opportunity to work with Plastic Bank, and for the equal amount of plastic that we produce, we purchase what are called plastic credits from Plastic Bank, and we purchase plastic credits to pull out the equal amount of weight out of the environment, or what would have been ocean-bound plastic. So as a part of our Biofinity family, our MyDay family, our Clarity, and our MySight One Day family that we just spoke about, we partner with Plastic Bank to be able to offset that amount of plastic out of the environment. We recognize that patients have strong sustainability values, and as a company, we do as well, and we want to be able to help support those with our Plastic Bank Net Plastic Neutral initiative.
Well, Dr. Rosinski, thank you for joining me today. This is Dr. Kerry Gelb for Open Your Eyes Radio on AM 1280, The Patriot. Great to see you, and thank you for your time.
Your eyes and your vision are under attack, damaging blue light from the sun. Your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with MicroMicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and MicroMicelle technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.